So,
Okay. Okay.
so welcome everyone. We're just gonna talk about point of care ultrasound today, and particularly the basics, and talk about the knobology and then kind of how to optimize image acquisition. So we'll start with kind of our PowerPoint presentation. So one of the big focuses of our teaching is on scope of practice. A big concern within cardiology and within internal medicine is that we're doing things with POCUS that we shouldn't be, and either making diagnoses that we shouldn't or not making diagnoses that we should. So really, it's an augmentation of clinical decision making that surrounds a specific question. It doesn't replace other information, history, vitals, exam, labs, and should not be used in isolation, just like any exam or any test. I think radiology or imaging tests are a little bit higher risk for using them kind of in exclusion, because they seem to carry this kind of definitiveness. If you say the F is X, kind of leads to premature, closure of your decision making. So you have to be careful as far as that goes. So decisions by IM residents and all of us need to fall within a reasonable scope of practice for your level of training. And for us and for you guys, bedside echo doesn't replace a formal surface echo, and shouldn't be really used as such. So the questions that I think are appropriate to answer are, statements that can be made based on POCUS, really are global function. So EF above or below 40%, I think, is a reasonable cutoff. Is the IVC distended, non-collapsible, or non-distended and collapsing, just as far as a volume status examination? Is there a large pericardial effusion? And tamponade, again, is a clinical diagnosis that can be helped by your echocardiographic findings, but certainly is not a slam dunk diagnosis by the echo. And then is the RV severely dilated? So this is just looking at your Parkland machine, and basically just kind of the knobs and what you should assess from it. As we know, the echo probe is this 4 to 5 megahertz probe. It's called a phased array probe. The crystals that actually emit the ultrasound waves are packed in really tightly and allow, to you to get in between the rib spaces with the phased array probe. Over here, you see your vascular probe, which is a little bit higher megahertz, give prettier pictures, but less depth. And the way the crystals are arranged, you wouldn't even be able to see the heart particularly well. Other things that are important on this particular machine, you'll see in the top right, is the transducers, how you actually change between transducers, the L10 and the P4. The exam type, this will give you optimal settings. So if you click exam types, you can hit cardiac POCUS, and that'll help you out. The other things that are important here is your depth. Over on the right side, it's a tab here. If you want to change basically the amount of contrast or gain that you have, it's the wheel, so turning it up or turning it down. Here's your Doppler and your M mode respectively. If you want to turn M mode or Doppler on, you just push the button in, is what allows you to do that. The other things that are important, this little purple guy is really nice. So it's an optimized image. So it actually will optimize the gain for the image that you have portrayed. Calculate and measure can actually let you measure things. The freeze button will freeze your image, and then you can use set and the wheel tracker to measure things, etc. And say you want to store something to send it to somebody later or to show your attending later, the store button is right here. So those are kind of the typical Parkland machines settings. The one at CUH is similar, but it's a touchscreen. So it has all the same things, but they're all based on touchscreen. Some of our smaller ones will be on an iPhone, but will look similar as far as the ideas to this. Anything on that, Mark?
Sorry, I'm muted. Nope, nothing else.
So that's kind of the basic knobology. This is just a little bit of an up close. We're actually switching between exam types. The cardiac POCUS and etc. will be on this line here. So you actually use this hard dot to push in to choose which one you specifically want. So jumping in, and getting our image, and we'll talk about kind of optimization as we go. The parasternal long axis view, as we know, second, fourth intercostal space, just to the left of the equilibrium, with the probe marker pointed to the patient's right shoulder. So the probe marker on any machine will be a small little dot or a line that you can feel. similar to when you're doing central lines, etc. So by convention, it's going to be pointed to the right shoulder. And you'll see a small little P or a circle or a white thing up where the reference point is that works or shows similarly to what the probe marker is. And by echo, by convention, it'll be in the top right corner here. So the peristernal long axis view, you see the RV, the LV, anterior and posterior leaflets of the mitral valve, LV free wall, your left atrium here, your aorta, aortic valve, and what we call the LVOT, or the left ventricular outflow tract from here. Issues that people have as far as optimization go on the peristernal long axis view can be challenging to get between the rib spaces effectively. So really what you want to do is you want to move this probe up and down the patient's chest wall till you find cardiac imaging or find cardiac flash, and then make small adjustments by fanning to find what you want. So optimization on the peristernal long, you should be able to see all of these chambers, but really you want to see the aortic valve be nice and right in the middle and thin pliable leaflets. And you want the LV to be elongated. So if the RV free wall is coming in deeper than the apex, if it looks like the RV is making up the apex, that means you're not optimized. And if you can't see the aortic valve particularly well, then you're not optimized either. That's the peristernal long axis view. Questions about that? I think you guys already know this pretty well. Okay. Peristernal short axis view, we're turning 90 degrees. So the probe marker faces the left shoulder of the patient. So really the way I think it's most helpful is you find your nice peristernal long axis view, whatever is directly down the middle of the peristernal long axis view, that's what's going to show up on the peristernal short. And so you take one hand and have it in a nice peristernal long and physically turn it to the peristernal short. So here we're seeing a variety of things. So you see the RV free wall here. Left ventricle should look like a nice donut. The LV systolic pressure is, say 120 is on average. The RV systolic pressure is about 25. And so the LV should always overwhelm the RV. And so it should be a nice circle. If you see flattening here of the interventricular septum, then you know the RV pressure is higher than it should be because it's starting to impede, on the LV. This is a nice view when we're looking for effusions, where they are. This is a nice view to look at global systolic function of the left ventricle. You can see how well it's squeezing. And then we use it for wall motion abnormalities, which is a little bit outside the scope of your guys' bedside echo, but you can see all of the walls really nicely. For reference, the interventricular septum is here in between the left and the right ventricle. The lateral wall is directly opposite of that anterior wall, and the inferior wall, so how we're describing it. We talk about this at the mid-papillary level, and so you can see the papillary muscles here and here respectively. And the reason why is the interventricular septum here is muscular. If you go higher, it's not muscular anymore. And so if you want to talk about wall motion abnormalities and squeeze, you need to be at a level where all of it is muscular. So this is a nice round view. If you get off axis, meaning it kind of looks like an oblong shape, it's really going to kind of mess with your perception of the ejection fraction as well as the walls. And so you really want to make sure that it's nice and circular, and then you're cutting it nicely right at the mid-papillary level for the peristernal short. I think if this view is done well, it's the easiest to kind of assess some of the cardiac parameters. But oftentimes you'll have a little bit, being a little bit off axis, which can affect your decision-making. What kind of my thought is. Okay, that's that. Questions there?
Yeah, I had a quick question. So when you're trying to do a POCUS on POCUS and trying to get the peristernal long and short, particularly with patients who are a little bit bigger, if we're not able to get good windows and stuff, do you guys have any tips and tricks on how to try to maneuver that?
So the big thing for me is moving up and down. And so, you're going from the first, second, third, fourth rib space, moving slightly the opposite direction, and just trying to find any cardiac flash. When you find any cardiac flash, then you can kind of maneuver, in between the rib spaces. If they're, quite large and you're really having trouble, you can roll them up slightly on their left side. That can help because it brings the heart down. More important for the apical four-chamber view that we'll talk about, but that's a potential. With females, depending on how much breast tissue, et cetera, they have, it can be challenging to kind of maneuver around that. So that certainly can be a challenge. And then always remember that people's cardiac anatomy is different. And so let's say somebody, for whatever reason, they have a large pleural effusion or kind of mediastinal shift. Things can be shifted one direction or the other. People that you tend to have a hard time getting good images on are people that are quite obese just because of scatter from the ultrasound waves. But even harder oftentimes are very, very skinny people because you can't actually get between the rib spaces. So those are people that I actually find most challenging. And really that is one of the things you can do is particularly if they're skinny, is have them take a deep breath in and hold it. And so that, it makes the inner rib space a little more profound. And so you can actually kind of get better images. Sometimes your images will be better if they hold a breath that's out. And so you can look for either of those if you're kind of swinging back and forth between breathing patterns. Mark?
No, totally agree. Small adjustments with the probe. And then just like Spencer said, obviously not all patients can lie in the left lateral position, but that does help positioning. And then for some patients, there's a lot of variation in your image quality just with respiratory cycles. So just like Spencer said, it's worth just trying to have them take a deep breath in, hold it just for a couple seconds, see if you can get a better image, and then likewise do the same with expiration. That can make a pretty good difference. And then the other thing is, we'll go through the different locations, but some people have great parasternal images, and then for whatever reason, they have horrible apical images or vice versa. So being comfortable with all the different views is really important because sometimes you can glean a lot from one point on the chest wall and not from others.
Absolutely.
Thanks.
Going further on the parasternal short axis view, changing your angle of where you're shooting is going to give you different parts of the heart. So as we know, shooting at the mid-papillary level here will be the view that we saw previously in C. If you move this up to B, you're cutting across the mitral valve, and it's called like a fish mouth of the mitral valve. If you continue to go superiorly or towards the base of the heart, you'll really get into the aortic valve. And so you'll see a nice trileaflet aortic valve, interatrial septum right here, left atrium, right atrium, tricuspid valve. This is one of the areas that we actually look for tricuspid regurgitation on this view, as well as aortic valve pathology. It can be, you can get into rib space issues. So sometimes you actually have to slide slightly down to shoot that superiorly into the chest wall. So that's kind of the helpful different views of the parasternal short axis view. This is just another view of the mitral valve or the fish mouth view of the parasternal short axis view. So a lot that you can gain from the parasternal long and short. 90% of your echo should be done by the parasternal long and short. You really should know what you're looking for and kind of have a good idea of things.
And I'll just reiterate before we go to apicals what Spencer said before. Once you get to your parasternal short view and you have a good image, really the easiest way to get to the different levels of the heart is just by fanning the probe. So sometimes you do have to slide the probe. You guys know what we mean by those terms? When you're fanning, you're literally keeping the probe in the same position on the skin, but you're just tilting the tail of the probe either towards the base of the heart or towards the apex. So once you have a good parasternal short image, you really can get most of what you need at the different levels just by fanning. You don't have to slide a whole lot else. Because once you start sliding, then you immediately can start to get into issues with rib spacing, etc. So just a pro tip, or a tip, not a pro tip.
Pro tip. Echo boarded. He's yeah, that's right.
Yeah.
Do you want to talk about the apical bore?
Yeah, sure. So this is the apical 4, so you can see the location of the probe and kind of the bottom left of this slide. So usually you want to put the probe kind of in the mid clavicular space, which oftentimes is literally just below the nipple. For women, if they have large breasts, you obviously tell them what you're doing beforehand, but you usually have to kind of tuck the probe underneath the breast, kind of in the inframammary fold. And then the indicator of the probe is pointed towards the patient's left. And so what you'll see on the screen is the image that is up. And so, a good image acquisition for your apical four-chamber, you should be able to see the left ventricular apex, and that should be dominated in a normal heart by the left ventricle. You typically want both the left and the right ventricle in the image, and you can adjust the depth of the probe such that you can see the back wall of both atria coming in. So even this image that's shown is maybe cutting off a little bit of the back part of the left atrium there. And then you obviously want to be able to see both the mitral valve and the tricuspid valve here. Sometimes you'll get a little bit of the aortic valve peeking in, but really you really shouldn't see much of it in a classic four-chamber view. And so this is a good view looking at left ventricular ejection fraction. It also gives you a pretty good idea of what the right ventricular systolic function looks like. And then you can also look for pericardial effusions from this view pretty well.
Have you guys heard of the term TAPSE, or a function of right ventricular function?
From you.
From me? Is that what you said? That sounds right. So the right ventricle moves more in the anterior posterior direction, kind of in this linear line, as well as the LV, which has 3 layers of muscle. And so one of the ways that we assess right ventricular function is how much is it moving in this direction. So with M-mode, you can actually put a line across it and measure how much it's moving in each systolic cycle. But grossly, you can also just look and saying, okay, is it moving a lot? Is it banging away, or is it just not moving? That's one of the other things that we use this for, in addition to what Mark had said.
You'll see that reported in our formal echo reports. Oftentimes, if you look like in the fine print of beyond the conclusion, you'll see it usually a TAPSE number that's reported. There are limitations. The right ventricle is beyond the scope of our lecture here, but it's very difficult for us to assess objectively. So we have a lot of different ways of doing that. The TAPSE is one, but you can imagine it's only looking at one specific point on the right ventricle. So you can have a normal TAPSE and a very abnormal right ventricle, and vice versa. You can have a low TAPSE, but a pretty normal looking RV. So limitations is one thing for that, but a good general feel of what the right ventricular systolic function is. Anything else we want to do? Yeah. Okay, so then this is moving on to, this is the subcostal view. So again, obviously, where your probe is positioned is in the bottom left of this PowerPoint slide. So you are, you can kind of palpate for the costal margin. You want to put the probe just underneath, then angle back up towards the patient's left shoulder so that you're angling back towards the heart. This is one view that can be a little bit uncomfortable for patients sometimes, because you do kind of have to press down, and kind of see how in this picture the sonographer is kind of pressing down on the skin and getting the ultrasound tucked underneath that rib space, so that you're not going through the rib spaces, you're actually going underneath it. And sometimes you do have to push with a little bit of pressure, and so it can be uncomfortable. You usually also have to increase the depth with this position, because there's more tissue in between where your probe is and where the heart is, so it's a little bit deeper. And then if you get a good one, you'll get basically what's shown here, with all the structures as they're labeled. This can be useful for pericardial effusion. It can also be useful for all of the stuff that we discussed before, particularly in patients where you're having a hard time getting either peristernal or apical views, like in patients that have really bad pulmonary disease, or in really skinny patients like Spencer was saying before, intubated patients too, because with positive pressure, it becomes very difficult to image sometimes. And obviously those patients, we can't turn on their side. So this can be your friend. Usually this is the easiest image to acquire, to be honest. Although sometimes it can be difficult, but usually this is a pretty easy one to get good pictures of. And
just
then
a cardiology fellow's best friend when we
exactly. So yeah, we can see all of these structures. You can look for pericardial effusion, EF, RV size, all those things, just generally speaking from this view, most of the time. And then from here, you can get to your inferior vena cava or your IVC view by making some adjustments with the probe, which I don't know, is the next slide that or no? No. Okay, good. So, oh yeah, it is. Okay.
Yeah, it's not great. I don't know where the picture went, but anyways.
It's okay. You basically what we do from here is you can imagine we know how the IVC runs, right? It's running vertically in the body. So you basically want to change the position of the probe such that the indicator is pointed up towards the person's head, and then bring the probe tail up so that it's no longer like flat or 45 degrees. It's actually perpendicular to the body. So you're kind of bringing it up so it's straight down. So the probe is perpendicular to the patient's body and the indicator is pointed towards the patient's head. And then what you'll see on your image screen is the IVC running basically horizontally across your image screen.
Perfect. Okay. Let's see. Okay, I'm off mute. So that's kind of the basics, which you guys know at this point. We'll get into a little bit of clinical correlates just because it's helpful to hear, and then we'll do maybe a case or two at the end. So the first clinical correlate that I wanted to talk about is something called E-point septal separation. This is something that some of our pulmonary faculty like to use, and it's kind of an old school way of measuring ejection fraction. So what you're going to want to do is take the peristernal long axis view, get a nice view, hit the M mode and position the marker or the line, the M mode, over the anterior leaflet of the mitral valve. And what you'll see here is this is a time on the x-axis and movement on the y-axis. So you'll see this anterior leaflet of the mitral valve moving in and out and diastole and systole respectively. In a normally functioning heart that's of normal size, the anterior leaflet should become very close or hits the interventricular septum. And so you'll see it be closer to the interventricular septum here. And you can actually measure that. And so that measurement is called end-point septal separation, or EPSS. The lower it is, or the smaller the distance, the better. The worse it is, or the larger distance, the more impaired the ejection fraction likely is. We typically use 5 to 7 millimeters. Less than that's a good ejection fraction. Greater than 10 is typically impaired with reasonable confidence on average. You can use this in addition to your kind of global view or global sense of what the ejection fraction is. Is it squeezing well or is it squeezing poorly? There's no, some people have asked me, how do you know if something's a good squeeze or a bad squeeze? It really is to some degree just, a sense and common sense from that perspective of, is it squeezing well or not? And the majority of time, it's actually pretty good. There was a study of cardiologists against med students looking at this, and really after 10 to 20 echoes, the med students did pretty well. So, from a global perspective of squeezes, you guys are usually right on from that perspective. The second is assessment of volume status. So Mark just talked about how to obtain the IVC. What I like to use when on bedside echo is kind of a parameter of 2. Is it high or is it low? So the first is it very distended, which is we say above 2.1 centimeters, and is it not collapsing with respiration at all? And so that's consistent with an elevated JVP or an elevated right atrial pressure. If it's small and collapsing consistently, then it's a low. Anything in the middle is kind of a mixed bag or mixed picture. But it can be kind of more of a bimodal, I think, for bedside echo is probably the most appropriate way. Remember to correlate with your physical exam. It's only one piece of data. If they're taking deep breaths or they're doing other things that can mess with your distensibility. If they're on positive pressure ventilation, it's the opposite. So it should not collapse. And so the biggest studies done on ventilated patients are 8 to 12 cc's per kg, paralyzed patients who are riding the vent. And if there was a distensibility as opposed to collapsibility of 15%, they were volume responsive. And so some people will use that, but how many of your patients are, meeting those parameters? Very few overall. So use IVC as kind of more of a bimodal type picture. In PEs, we hear about echoes a lot, kind of helping with RV function and size. The big thing is are there signs of right ventricular strain? Again, this is not a diagnosis of PE, as you know, CTA or some other modality is the diagnosis of it. When we're looking for signs of strain, we see RV dilatation, abnormal motion, and septal flattening, like we discussed in the parasternal short, impaired right ventricular function, and you can kind of look at that grossly. On the bottom are just some parameters of morbidity, mortality associated with different cardiac parameters. Really, you can modulate your understanding of somebody's risk with cardiac parameters, some of which can be done by POCUS. So I want to talk about RV dilatation because that's a question that's come up a lot. So apical four-chamber view, we typically want to look for the ratio of LV to RV. LV should always be larger, and RV should be somewhere around half to 2/3 the size. If it's greater than 1:1, then it's dilated. And we're using that basically as a measurement across rights above the tricuspid and mitral valves, respectively. There's some other parameters that you can use that are more for formal echo. But for you guys, I think really looking at the LV compared to the RV is probably the most important thing. This is the septal flattening that we talked about, basically, where you have, instead of a nice D, you start to have a circle, or a nice circle, excuse me, you start to have a D or flattening of that interventricular septum, which we see with increasing right-sided pressures, particularly acutely. McConnell sign is something that's specific to RV strain in the setting of PE, but it's kind of a little bit challenging to pick up. But essentially, you'll see that where the base of the RV is not moving particularly well, but the apex is either spared, so moving normally, or will look like it's hyperdynamic. And so that's a sign of severe RV strain. So if you'll see that in either our echo reports, or you can ask the pulmonary faculty or whatever when you're looking at a bedside echo in a PE patient of, hey, this looks abnormal or looks kind of funky. What do you think? I think it's dilated, and the apex seems to be moving a little bit more aggressively than the rest. So as you know, in a pericardial space, there should be about 5 to 50 cc's of serous fluid. With excess accumulation, really it's about the time of collection. If it's over a short period of time, somebody can be in tamponade with 100 extra cc's of blood. And over a long period of time, I've seen somebody have 2-3 liters in their pericardial sac with that amount of stretching without any issue, really. And so it's kind of really dependent on the time that pericardium has had to relax or basically grow over time. So the parasternal long axis view of what we're seeing here will show anterior and posterior pericardial effusions. It's important to locate the descending aorta. Anterior to the descending aorta is typically a pericardial effusion. If it's posterior to the descending aorta, it's more typically a pleural effusion. So that's a really important marker on the parasternal long axis view and whatnot. So that's kind of what we're looking from that perspective. For you guys, the big thing is clinically, are they in tamponade? Is hypotension, muffled heart sounds, having pulsus paradoxus, and then putting a probe on and saying, oh, that's a significant pericardial effusion, and calling us for kind of to discuss it. That's really what we would want you guys to do, or expect you guys to be able to do. And that's Beck's triad for when you guys are doing medical jeopardy at some point. That's a classic one that comes up. So help you beat the faculty, which is kind of one of the most important things. Those were the basics that I wanted to talk about, just really remembering those scope of practice, which is important, and then kind of how to assess. I think I'll turn off the recording.